Ladies and gentlemen, I'm delighted to present the second autumn-winter series of webinars from UKDHC. And I'd now like to share with you a short series of slides before we get on to the informal discussion. You can see that we have a group of speakers. I am chairing this session. We have Amani Budota, who is now chair of the Education and Training Committee. David Wright, who is UKDHC Commercial Director. And Masha Gaganova, that I'm going to describe as an activist because she is so active on social media. And it's wonderful to have you all here as speakers. And I'll now run through a short presentation about from vision to reality and how the Real Deal is supporting NHS and care staff. Now, this slide and the first 4 slides are taken from a presentation we made on the 13th of May, when we set up the Real Deal. We were concerned that both the NHS and social care had been left behind in relation to digital skills and digital training, and we wanted to contribute. And we are extremely grateful to UKDHC sponsors who have actually contributed financially to us developing this program. In December 2024, our executive committee recommended that we proceed with the Real Deal. And in January 2025, the planned Real Deal was presented at a UKDHC webinar. So what is the Real Deal? It is remote evaluation and lessons, that's real. Digital expertise assisted learning, deal, the Real Deal. What we have provided is an online self-assessment for all professional health and care staff to improve their digital skills. With each of the teaching modules, you get a signed certificate, assuming that you pass the test at the end of the module, confirming that you have improved your digital skills and addressed some of your deficiencies. If you don't like what our certificate says, you can throw it in the bin. And later on, if you want, you can repeat it. But we would like you to take that certificate to your employer and suggest to them that you might be supported in improving your digital skills with digital skills training. Our website signposts to courses that are available to cover these deficiencies, and there are lots of courses that do that. There is an option for you to join the Real Deal free teaching mini modules, which are available for NHS and other healthcare professional staff free of charge. And our first mini module from the University of Central Lancashire launched on 18th March 2025, with new modules in April 2025. The certificates for mini modules are completed satisfactorily. Now, this is a couple of slides from Jane Fitzgerald, who has put an enormous amount of work into developing this program. And you can see that she's course leader in health informatics at the University of Central Lancashire, that is now renamed the University of Lancashire. She has 25 years of experience in distance learning, and her students work in health or social care. And her course is divided up into different parts, dealing with information information, data and content, creation, innovation and research, technical deficiency, etc. So here we are with what was the plan in May 2025, and Amani, who is now chair of the Education and Training Committee, is going to take over and talk through the plan as it was in May 2025 and as we have progressed into September 2025. Amani, can I please hand over to you?
Yes, thank you so much. So, as part of Education Committee, led by JM Fiscal until last month, we have developed multiple courses collaborating with different universities. The first course being the Real Deal Self-Assessment. So, for the Real Deal Assessment, it's a free digital competency self-assessment module designed to help health and social care staff evaluate their digital skills and also get personalized reports to guide their professional development. And I've personally have taken this course, and it's quite interesting to see there are still some gaps being working in digital health for last 10 years. So I would appreciate if everyone takes it and give us some feedback on things that you found interesting and also something that you wish was there that's not currently present there. And next was also about the introduction of health informatics, and this is something what we call bite-sized formats, where the whole, as you know, health informatics can be as broad and a multitude concepts including it. But what we've tried to do is to give a more of an introduction through bite-sized content, which the whole course is 6 to 8 packages. It could take just 1 to 2 hours, and it is to give an overview of how data is collected, stored, managed, and also how it can still be used to improve patient care itself within the health sector. And followed by this, we did another course on digital safety that's released on May 2025. This is from University of Warwick. And that's more to deal with and it's a very new module on our list that introduce key concept of safety, risk management, and mitigation of organizations and manufacture of health related products. And this kind of also involves in emails. How do you familiar with digital literacy as well? And there's another ongoing courses that we will be pursuing soon. That will be coming in the later months from University of Swansea and lead packages. And for the first overview, I can share the UKDHC website where these courses are currently present. So if you go on to UKDHC website, there's this column on the top called courses, and we do have those 4 courses that we've presented. And the Real Deal is the one that where you can take a assessment of your digital skills. And the assessment is actually through multiple levels, covering multiple concepts, I would say. The first thing is about technical proficiency. So you can either choose each one after the one, and you do get all the modules for free. And these modules are built essentially to uh, essentially as a response to the critical need of upskilling the health and care force in the digital health as per the 10-year NHS plan as well. And so we have split them into multiple areas: technical proficiency, communication, creation of data, and also about content, consent, all of the info security related things into another bucket of things: digital identity and learning and development. So I can show you as an example for information and data consent. You've Then this opens a quiz kind of thing and seeing what are the things that you're already proficient at, and it can give you gap analysis, completing each quiz after answering basic questions essentially. And once we finish this, we go to the next page of the next questions, and you kind of get a results about the stage that you are in, and maybe recommend some courses as well. So that's for the Real Deal. I'll take a break for any questions before I move on to the next course.
Before you do that,
Yeah.
can I ask you, Amani, to go back in to the front, to the landing page of our website and just show us that, because we missed that because it overlapped the slides I had.
Okay,
Just go into the front page.
absolutely. Yeah, so this is the UKDHC website, the UKDHC info, as you're familiar with, and then this is about us, members, and the third tab here is the one that will be pointing you to the courses. And in the courses, the assessment that I was talking about is the real deal. So you click on courses and then go to the real deal. This is essentially the remote evaluation that looks at your digital expertise in assisted learning. And if you come scroll down to the bottom, like I was mentioning earlier, this is through different assessment areas, and you can pick on by each category. And this is a six areas that we've tested it. We've been currently testing in. So it's all the six courses, all the six tests are free.
That's lovely. Any questions from the audience that we have here? Can you, Amani, how often can you go back and repeat each of these individual units of teaching?
There's no limit currently because it is through email ID. You can always go back and refresh, especially the courses. They're just content that is available online. So there's no limit.
And the other thing that we are looking at is for people to do their self-assessment,
Yes.
do some of our courses, and then come back again. Can you explain the research that you and Masha are keen to push forwards? And I'll then hand over to Masha.
Yeah, absolutely. So the idea is once we take a real deal, you identify the gaps and you have these resources in the courses addressing each of those areas that we've just discussed. So we would like to collect the data on a chronological order of the tests that you have taken, courses that you have taken, and if the scores have improved, or if there's any, and also the feedback of the group of people that are taking the test, a survey on who are the people who are taking these tests, what's the improvement level like, and what's the frequency that we would want to introduce the test as well. And Masha, happy to hear your thoughts on that.
Masha, over to you.
Thank you. Well, I think it's really about the different information that we can get from the data, and I think until we have that, there's a lot of hypothesis around, right? But it would be amazing once we have the information to see perhaps something that we thought people would struggle with, but it's the contrary. They have high ranks, for example, and then we can pivot for next year, and what would be the areas that people need help with might be different to what we put out right now. Would be also interesting to see it in relation to the type of the work that they're doing and where they sit in their organization, so that we can also see certain trends there, and also pivot and maybe have even split
Specialization.
the offerings, right? Depending,
Yeah.
it's really hard to say these days. Like it used to be much more streamlined, but right now, hierarchy, your role, trust, ICB, place in it, everything can be completely different, and it's unrelated to the digital skills that you're gonna have, right? So that would be really interesting. Geographical coverage as well. I would want to look into this, because we know different NHS staff is supported in a very different way depending on where they sit. Yeah, so there is so much that we can do with given the data provided. The thing that I honestly haven't found the way to do yet is the real examples, like the real stories. Like if anybody has done the assessment, have actually took it to discuss with colleagues or their managers, have actually done the courses, and that changed something about how they approach their work, or it led to them getting a new job progression, right?
Yeah.
Or it led to them implementing something new in the workflow that they have. That to me would be the real deal win, right? That will mean that we're actually making a difference. It's early days, of course. I mean, we're talking since May. It's amazing what we have been able to produce in a short space of time, and of course, it will take a bit more months to actually see the harvest, the results of it, but that would be interesting to interview the people who've done the courses, if they're willing to share a bit more behind the scenes, behind the data, because of course data says a lot, but it will never be able to draw us a full picture, right, unless people share. Yeah.
What I would
Absolutely.
like to see happening is some of the hospitals in the UK coming to us and saying, we would like you to develop a course on this because this is a subject that we believe we need to improve the digital skills on. And we would be very happy to do that with the support of our sponsors and do it for specific hospitals as they wish. The problem we have sometimes in the NHS is that we tend to have a silo mentality, so that one hospital tends not necessarily to work with another hospital. And yet there are all sorts of benefits from working collaboratively. And we are offering that opportunity to hospitals across the UK if they're interested. Any comments from anyone before we go on to David?
Just one, Angus, if I may.
Yes.
I've always used the expression data is currency. If we get some data out of this, the feedback, that's the currency that we can use for leverage. So if we can think about that, once we get some decent data, we can use it as leverage to influence policy. That's the way to go.
Yeah, and I'm not sure if we collected any feedback on people who have already done the service, but we do have email list if I'm not wrong, and Bell is going to reach out to them with some survey questions, anecdotal examples as well of how this impacted, in addition to a regular quantifiable service.
Oh, beautiful.
So Belle is our intern, and she has been tasked with developing an analysis of the teaching program and how the teaching program can be evaluated. And that is in progress at the present time.
Yeah.
But we're not talking about high-level digital skills. We're not talking about coding. We're talking about basic things like using spreadsheets, like using tablets, or if I'm allowed to call them iPads, because that is what people are doing in the workplace, and many people have not learned the digital skills that our children leaving school have acquired during school days. And that's because they're 20 years further on. And we're trying to help them with that. And we are very, very keen to give them any support we can to improve these skills. Because if you become more digitally competent, you will be able to offer a much more efficient service, both in the NHS and in social care. And with that, I'm going to hand over to David, who is going to talk to us about what his aspirations for this program are and how we might also help and support social care. David, over to you.
Thanks, Angus, and thanks, Masha and Amani. That was interesting. It's from my perspective, I'm actually going to take a really bigger picture view, as I believe that UKDHC has a role to play across the spectrum of healthcare delivery within the UK. My background is I've only been in the UK for 2 years. I've been away for 40 years, but I've worked in many different health systems, mainly Australia, also the Middle East, and consulted with the WHO and the European Commission on health systems. But coming back, I want to try and make a difference back into the UK, however small, but I really want to try and help along the way. So I'm going to take a big picture view. I'm going to show you, I'm going to build up a slide. I want you to think about being in a helicopter, looking down on the health system in the UK. We're looking down and we're going to build it up. So just bear with me while I share my screen. Let's look at this as a health systems framework. UKDHC has a role to play within this framework. That's the biggest, that's the message I want to get across this evening. If we look at complexity on the X scale there and volume, underneath this curve that I'm going to show you is all the healthcare that's delivered in the UK. There's 63.8 million. But when we look at it in virtually three segments, what's done in secondary and tertiary, what's done in primary, and what's done in self-care. There's the volume under the curve. Self-care is when we look after ourselves. We get a headache, we decide what to do. We've got our watches, we look at our steps, we look at our heart rates and so on. This is self-care. It's the education. That's really, really, really important, self-care. However, these are the problem areas. These are the real problem areas in healthcare, wherever you work in the world. Admission planning, discharge planning. Where do people go? Ramping of ambulances at hospitals. Discharge planning, you've got nowhere to discharge them to because community care is not set up. This one, there's too many people going to a GP. 3.3 visits per annum on average for 63 or what was it, 63.8 million people. 3.8 visits per annum. Some people use a lot more than that, lots and lots more, the regulars. Some people don't go at all, but that's the average. And this area here is where the worried well end up. So for the last literally 30 years of my career so far, before I get to that, this curve is going upwards. It's expanding because of the age population, the unwell, the comorbidities, and so on. This is expanding very slowly and putting additional pressure on the health system. When we look at what the 10-year plan is, those three key issues that Darcy and has built into this 10-year plan, moving hospital care to the communities, analog to digital, sickness to prevention. This is what needs to be done. That line needs to be moved to the right. That line needs to be moved to the right as well. So those two vertical lines need to move. This is what this is all about. Those three areas, what Darcy talks about. If we can do that, it means that people in hospitals are the ones that are really sick. If we can get hospital in the home programs, virtual wards in place, community health programs in place, even better. We will need digital skills and digital applications for that to work. And there are lots out there at the moment. Remote patient monitoring, virtual wards, etc., etc. There's lots happening in that space. And that will be the pressure on the health system over the years as this is implemented. So basically, strategies to move these two lines to the right. That's what it's all about. However, this is an area where we can actually start that ball rolling, educating the community. There's a lot of misinformation out there all the time to do with healthcare. Lots and lots of misinformation. Does UKDHC have a role to play? Possibly. There's a project in there somewhere that we need to work on, clarifying information. I know Professor Wallace has got his mind set on doing something in that area with regards, verifying information. That's potential for UKDHC into the future. I'm a great believer that GPs must take a stronger approach to community health. You'll read very much about IHOs in the next couple of years. Well, before, they're already starting. Some of the very exceptional trusts that are out there, they're already working on this. But have they got the skill sets on their board to understand population health, community health, working closely with stakeholders. They've been focused, the trusts have been focused in this space since they've been set up, managing budgets, managing that area. They haven't been, these IHOs, they're thinking about this, all of it. And those of you that, if you come across John Oldham, this is where his work's going to make a big influence. Oldham's talking about this collaboration and setting up these IHOs. So in the end, and these are going to be the buzzwords going forward, you'll be hearing a lot about this in the future: commissioning of care, delegated capitated budgets, population health management, provider collaboration, and that all needs trust. It needs trust with regards to transfer of data. It needs the use of data to change it into policy. But basically, these IHOs are going to be very, very influential if the NHS are going to move forward with this 10-year plan. Commissioning of care at this space, my worry in the work that I've been doing is focusing on social care. It's the nursing homes, the residential homes, the hospice care. 5% of our health when we are ill is spent in here. 95% is outside of the hospital. This is where we need to focus our efforts, which gets us into the sickness to prevention space. How can UKDHC help? Well, we can help in many ways in this space. I'm not, as Angus said just now, this is not just about the highly skilled IT and IM that's needed within hospitals. This is about the integration of care across the board. How can we help a nurse working in a care home more efficiently understand how she's utilizing IT, how she's utilizing communication and handover between her when she's dealing with one of the residents and a visiting GP? That communication of information, the transfer of information from the residential care if somebody goes into hospital and vice versa. This is all about that integration and using IT and IM effectively. The real deal is the very, very tip of the iceberg. The real tip of the iceberg with regards to providing assistance. UKDHC has a tremendous opportunity to influence working across the board. If you don't get it wrong, and this is this 10-year action plan, if you get things wrong in any kind of this these equations, now the research has shown, and I've got it here, Forbes reckon that 75% of IT projects fail. Harvard Business Review, 70%. McKinsey, 66%. They fail. They did not meet time, budget, or goals. 44% of IT projects. 41% actually fully met. And 15% missed everything. Didn't get off the ground, they were stopped. How much money has been wasted because of poor planning? I've read through the NHS 10-year plan, probably now, and it's a very, very long document. I've looked at the précis, I've looked at the exec summaries and so on. And I look at the hurdles along the way. If we don't get some of these things right, the vision is there, what we want to do. And I say we, I'm a UK citizen, even though I've worked in Australia for 40 years or whatever. I want to get behind this and roll my sleeves up and help in a little way possible. But if we get things wrong, as I said, the vision is there. If we haven't got the skills in place, whether it's in residential care, whether it's in the IHOs, whether it's in the hospitals, discharge planning, it causes anxiety among people, the professionals working there. If there's no incentives, is it going to save me time? Is it going to save the trust money? If there's no incentives, people resist. If there's no resources available, people get frustrated. If there's no action plan, and this is my worry at the moment, when I read through the NHS 10-year plan, I want to see an implementation plan. I want to see a roadmap for the next 10 years, the stepping stones, how we can get people behind this, stakeholders, local government, local councils, population health planning, and so on. 63.8 million people needed to be educated about this. I use this as an example. The best mission statement I've ever heard was by the chief executive of Qantas, would you believe, the Qantas airline. His mission was to get Ansett. And I said, what do you mean get Ansett? He said, I want to do everything better than the other airlines. Whoever pulls the checkout, whoever gets the baggage, whoever serves the coffee, I want my team to be better than everybody else. So the vision for us is to develop a health system that is going to meet the needs of patients, not the waiting list, not the ambulance ramping, not the cancer treatment that takes too long. We need to get these in place. In UKDHC, we need to have a voice and provide input into strategies at the very beginning. Let's make ourselves heard. Let's provide. I know we've in the recent months, we've had conversations with government. That needs to continue. We need to get assistance from all of the team of UKDHC are unpaid. They're volunteers. They want to get behind this. They want to improve the system. The Real Deal can assist with skills development, understanding where the vacuums are, and individual, not the big teams, not the hospitals, but the individuals realize where they can improve. We can assist with local plans as we build up our local representatives in different parts of the country. That's what we need. We need members to join, to come forward and be part of this journey, whether it's at the local level, regional level, or national level. Get involved. We can assist with supporting change. Otherwise, we're going to have false starts, frustration, resistance, anxiety, confusion, and we won't get the change that we require. This is one of the biggest initiatives I've seen for a health system across the board. And I take my hat off to the leaders in the NHS who've come forward with this plan, but they need to work with as many groups as possible to make this work. And UKDHC is there to help, and we'd like to get members involved and developed along the way to assist. Happy to take questions, Professor Wallace.
Thank you, David. A lovely presentation. I just need to clarify a couple of things. You mentioned IHOs, but in the UK, that's not a widely used expression. I assume it's integrated health organizations.
Yes, and there's 43 that are going to be starting at the moment. They've been targeted. Sir John Oldham is canvassing for more to be involved. They went to the market and asked for groups to come forward, whether it's GP foundation groups, and they will end up, as I said, the buzzwords in the near future. Within 12 to 18 months, there'll be capitated budgets at a local level. There'll be population health planning. They'll be deciding on what, working with hospitals on what resources used. It really is going to make a change to the way the health system in the UK is delivered. That's if all these things are put in place. Otherwise, we're going to get, as I say, confusion, anxiety, resistance along the way. It needs build change in from the beginning. IHO is Integrated Health Organizations, and they will have representatives from hospitals. They might have local government. They've got to set up their own governance arrangements at the moment. They will end up holding the budget, a capitated budget. And the model that has been mapped on, I'd say, is the accountable care organizations out of the US. In Australia, they're called the PHNs, Primary Health Networks. In Spain, you've got a really good model in Valencia called the Alzira model. That's worth looking at, which once again is driven by the population, the locals. They decide what resources are being spent and how it's used.
Thank you, David. And for clarification, David was the Chief Executive Officer of the Royal Australian College of General Practitioners and totally transformed the GP service in Australia over the 8 years he held that post. So he is knowledgeable about these things and has experience from another country and is full of information about what might be done, so much so that a lot of the Middle East countries have contracted him to help them with their health services. So thank you for that, David. Lovely presentation. I'd encourage you to unmute your microphones and come in with any questions that you have about how things are and how you feel they should be going in the next couple of years. Masha, you're an enthusiast. I know you're an enthusiast. You push things forwards on social media. Is it more TikTok or LinkedIn, or which one is your best
Just
one?
LinkedIn. I'm not that young, so no TikTok for me.
Right.
And I talk about change a lot, right? That's one of my key areas is support change and transformation in organizations. So that slide is very dear to my heart. I've shown it many times as well. And what I find oftentimes missing is leaders who sponsor the whole thing. Like who inside this organization is actually stepping outside or their role or taking on more in order to advocate for it in their peers and other stakeholders, because it's very hard from the bottom to do anything, and you do need some authority around it, right? And then how to find these people or nurture these people, because they don't just wake up in the morning and think I'm going to be a change agent today. Like that's not how it usually works. And we could maybe help in this area as well somehow, because it's about the mindset more than anything really, because these people then drive it. So how do we find them or build them?
Okay, the finance of the health service is funded through the Department of Health and Social Care. And they used to allocate funds to NHS England. Scotland is a separate domain. And NHS England distributed the finances in the way that they felt was most appropriate. NHS England is being dismantled at the present time. Nobody's quite sure what is happening, but it's the people in the Department of Health and Social Care who make the decisions, but they don't decide. It's the Treasury, the UK Treasury, that decides. And at the moment, they have to decide on whether to finance for defence, which has pressures on it at the moment, whether they have to finance for dealing with people who are crossing the channel into England. There are all sorts of demands on the funding, and we have to be realistic about it. But one of the problems has been that the health service has often wasted money because they've done it the wrong way. Now, I'd like to go to Zoe, who's got her hand up. If you can unmute Zoe and ask your question, that would be great.
Hi, Angus. Apologies, I don't have a camera on the current laptop that
No
I'm
problem.
on. So it's just to really to ask David. So I think sort of this idea of moving to improve prevention strategies. I think there's something about, do we need a sort of actively participating population in their healthcare, or do we just need to make it as easy as possible for people to participate and look after their health? And is there a role for digital there, sort of with the patient health records? And how, I mean, you know, I get texts regularly from my GP saying, please fill in your blood pressure to respond to this text, but I don't know what my blood pressure is unless I've got my own, you know, sphygmomanometer at home, or, you know, so it's a sort of, I was just thinking about, there's all these digital tools, but, you know, it's about the active participation or making it as easy as possible. I just wondered what you thought about that.
Well, thanks, Zoe. Well, you've answered your question, actually. There's two, they both apply. I'm a great believer that everything to do with personal health, if we can, we should make it tax deductible. That's a shift. These things, that's one. That would be easy.
So that's a smartwatch.
A smartwatch, you know, they should be given out to highly complex with people with comorbidities. You say you don't know your blood pressure. These things can do it now. Then you need information about blood pressure and what it means. Then you need information about, you know, the medication you're on. So it's access to information, access to local communities. I did some research a couple of years ago about these blue zones around the world, where people, you know, those communities that live over 100. Why? And there's one common denominator amongst them all. It's not running around like a chook. It's not eating vegetables all day long. The common denominator about all these groups, whether it's in Sicily or Japan or wherever around the world, it's community. It's actually within your community, the community groups around. So that's
coming back to you, Zoe. I think we are moving towards everybody over the age of 30 getting their own blood pressure measured. It shouldn't be done in a general practice. That's nonsense. But we have an issue at the moment. I did have high blood pressure many years ago. I'm on medication. I measure my blood pressure every day. My GP wants the blood pressure measurement. How do I get it to the GP? Well, believe it or not, I fill out an Excel spreadsheet, convert it to a PDF, email it to my GP where it's photocopied and put into my notes.
Yeah, well, my mum's doing the same, but she's writing it on a bit of paper and then walking it down to the GP and then handing it in. So and you know, so it's things like that, isn't it? I just think, you know, we've been using like, for example, the Patient Knows Best portal for about 12 years now, and we've been trying desperately to get other people within the organization and the trust to really maximize the benefits of having these sort of Bluetoothed, you know, blood sugar monitors, blood pressure monitors, and all of these things can have alerts on their patient portal, but people are just not using it, and they're just not really making the most of the facilities that we've got. And I'm just kind of wondering whether that's, you know, the sort of paternalism of healthcare or the protectivism. I don't know if that's a word, but, you know, like, are we prepared to hand some of this information and authority back to the population, or are we just ignorant of what is the potential that's there and why aren't we using it?
Zoe, Patient Knows Best is a great organization who honestly believe that patients should have their own information, they should understand their own information, and they should be able to transmit that information easily into their case notes. Mohammed, who runs that organization, I know personally because I worked with him when I was treating patients who were affected by thalidomide. I was a shoulder surgeon. I did a number of shoulder replacements on people who had been afflicted by thalidomide. And I got to know Mohammed very well at that time. And subsequently, we've got together since I came back into the informatics world. He's a great guy, and he's got some of the contracts for the NHS app, but not all of them. And what I found slightly strange is that the NHS app that you have in London is not the same as the NHS app that you have in the northeast of England.
Yeah.
It has different suppliers, different parts to it, and I don't know how integrated it is. David, you were desperate to come in there.
No. I go back to community. I'm a great believer in see one, do one, teach one. That's how medicine, you know that yourself. You had a supervisor when you were doing shoulder surgeries. It's see one, do one, teach one. If you can, kids at school should know what cholesterol is, what it means. They should be taught these things really early. They should be taught about blood pressure, early teens. The knowledge base needs to be expanded. It's osmosis. So that's what we need to do, is to move that line in self-care to the right, to stop the worried well going to GPs and blocking up those that really do need to be there. GPs should be more skilled. They should be doing a lot more procedures and getting paid for that. That was my strategy in Australia. I wanted to get the GPs more paid for doing more complex work and not click-clack medicine. Come in, see you next week, and get paid the same amount of money. That's nonsense.
Yeah. Belle, please come in.
I'm just curious, with increasing wearables, to the layperson, and with a lot of people getting quite excited about self-diagnosing with ChatGPT and other forms of AI, where do you think we draw the line between obviously the benefit of reducing the burden on clinicians and the potential risk of misleading patients who are getting over enthusiastic with unreliable information?
I think the government has a real problem because it developed the 111 service, which most people in the UK have utilized. It was developed with the best intentions, but anybody who has been through it finds it an unattractive phone number to phone, because you spend quite a lot of time answering questions from a questionnaire before you ever get guided into what to do. I do think people are going to use artificial intelligence more for their own health. The difficulty is that artificial intelligence is influenced now by social media. Unfortunately, it means that you can't trust everything that artificial intelligence is telling you. But I would encourage people as a first step to use it, because I do think that it can be helpful, but don't trust it completely. David, where do you see us going with
it's access to information. You just got to be discernible, and that's the challenge. It's the moral judgment, and that's the problem. It's actually deciding what information you're chasing if you're unsure, and what's available and where to go to.
Yeah.
And with the expansion of the internet over the whatever number of years, access to information has ballooned, and there's a lot of nonsense out there. So it's knowing where to go. If in doubt, go to your GP. But that's if you're in doubt.
Well, we do know from studies that have been carried out in Sweden that paracetamol is not associated with problems with autism in the children of mothers who took it. But if you go on the internet next year, you are going to be influenced by what other people have said about it. And that is a real problem and a real issue. And we need to be very, very careful about how we address that. I'm going to go around and just check there are no further questions from anyone. Zoe, before we finish, have you got any questions for us?
No, thank you.
Lovely. Amani, you okay?
I'm good. Thank you. Thanks a lot for the presentation,
Masha?
David.
All good.
David?
No, I'm fine. I'll leave you with one thought, actually, Angus. And this was from the president of a medical association that I was doing some work with. And this is going to cause a bit of a stir, but it wasn't me who said it. I'm just repeating it. He said 80% of what he saw as a GP, a competent grandmother could look after. Now, what did that tell me? You know?
Unfortunately, we don't have competent grandmothers anymore. That is the
Yeah.
problem. And if we do have them, they don't necessarily speak to the people in the family.
Well, I want a lot of more self-care, and I want GPs to take a real stronger role in working closer with tertiary care and the community. Thank you.
Belle, anything final to say?
No, just thank you. It's been really interesting.
Yeah. I'm going to close this podcast. Thank you very much for joining us. It's been an insightful discussion. Thank you very much, everyone.